Hello, welcome to today's session on the cardiac cycle. Our hearts are continuously beating to pump blood into the body. Each time the heart beats, there is an electrical event, that is, generation of an action potential, followed by mechanical events, that is, contraction and relaxation of the heart. The series of these electrical and mechanical events occurring in the heart with each heartbeat what is defined as the cardiac cycle. The heart is a four-chambered structure with two atria and two ventricles. The atria and the ventricles communicate with each other through the atrioventricular valves, that is the tricuspid on the right side and the mitral valve on the left side. The ventricles communicate with the pulmonary artery and the aorta through the pulmonary valve and the aortic valves. Whenever blood is collected in the right atrium from the superior vena cava and the inferior vena cava, the blood then is passed on through the tricuspid valve into the right ventricle, from where it is passed on to the pulmonary artery for oxygenation through the pulmonary valve. Similar to that, the blood on the left side is collected by the left atrium from the pulmonary veins, from where it passes on to the left ventricle through the mitral valve, and from the left ventricle to the aorta and to the rest of the body via the aortic valve. It is important to discuss here that these valves allow the flow of blood only in one direction. So the flow of blood is unidirectional through the valves. The opening and closing of the valves is unidirectional. The atrioventricular valves, they open into the ventricles and allow the flow of blood from the atria into the ventricles only, not in the opposite direction. If the flow of blood occurs in the opposite direction, the atrioventricular valves will close. Similar to that, the semilunar valves, that is the pulmonary and aortic valves, they allow the flow of blood from the ventricles into the pulmonary artery or the aorta only. If there is backflow of blood from the pulmonary artery towards the ventricles, these semilunar valves will close. So the valves, they allow the flow of blood only in one direction. The next important point which we should know or remember here is the flow of blood from one chamber to the other follows the pressure gradient. Always the flow of blood occurs from an area of high pressure to an area of low pressure. Whenever the pressure in the atria is higher than the ventricles, then the blood will flow from the atria into the ventricles. And when the pressures in the ventricles is higher than the arteries, the blood will flow from the ventricles into the arteries. The blood will flow from ventricles into the artery. This pressure gradient causes opening and closure of the heart valves. Consists of contraction of the heart, which is termed as the systole, and relaxation of the heart, which is called as diastole. During relaxation, filling occurs, and during contraction, ejection of the blood occurs. The time taken for this mechanical events to occur, that is contraction and relaxation or systole and diastole, is around 0.8 second in a person having a heart rate of 75 beats per minute. The cardiac cycle can be discussed in two categories, that is the atrial cycle and the ventricular cycle. Atrial cycle including systole and diastole of the atria with durations of 0.1 and 0.7 seconds, and ventricular cycles have duration of 0.3 systolic phase and 0.5 diastolic phase. It is important to remember here that whenever the heart rate is increased, if the heart rate is increased from 75, it has increased to 100 beats per minute, the duration of the cardiac cycle will decrease. But the phase which is affected most is the diastolic phase. The diastolic phase is reduced more compared to systole whenever the heart rate is increased. We will be discussing about the changes in the ventricular cardiac cycle, as the ventricular chambers are the ones which are going to pump blood into the aorta and the pulmonary artery. It includes the systolic phase and the diastolic phase. The systolic phase is further subdivided into isovolumetric contraction phase and the ejection phase. The diastolic phase into isovolumetric relaxation phase, passive rapid filling phase, slow filling phase, and active rapid filling phase coinciding with atrial systole. Before we go further discussing each individual phase, I'd like to explain to you or discuss about the term isovolumetric. Isovolumetric means the volume of blood or the volume of the chamber will not change. So it is isovolumic. And also the length of the cardiac muscle when it is contracting or relaxing will not change. So it is isometric. And when you combine these two terms, you can call it as isovolumetric. So during an isovolumetric phase, the size of the chamber will remain the same. The volume of the chamber will remain the same. Then what changes? What changes is the pressure inside the chamber. Whenever there is isovolumetric contraction, the pressure inside the chamber increases tremendously. And when there is isovolumetric relaxation, the pressure inside the chamber will decrease tremendously. So please keep this in mind as we go ahead to discuss each phase individually. Now let us start with the first phase uh, that is the diastolic phase. You can see here that the atria and the ventricles are relaxed. There is blood flowing from the atria into the ventricles. That means the ventricles are getting filled with blood. This is the diastolic phase. The semilunar valves are closed and the atrioventricular valves are open. Next follows the active ventricular filling phase. This coincides with the atrial systole. So the atria are contracting actively and they are pushing the blood rapidly into the ventricles. So there is rapid flow of blood from atria to the ventricles. This fast flow of blood from the atria to the ventricles produces a sound which you can call it as the fourth heart sound. As more and more blood accumulates in the ventricle, the pressure in the ventricle increases more than the atrial pressures. Once the pressure in the ventricles becomes higher than the pressure in the atria, the backflow of blood causes sudden closure of atrioventricular valves. The sudden closure of atrioventricular valves will create a sound that can be taken as the first heart sound. First heart sound signifies the beginning of systole. With the beginning of systole, the first phase of systole of the ventricles is isovolumetric contraction phase. You can see here the semilunar valves are closed, the atrioventricular valves are closed, and the ventricles are closed chamber. There is no change in volume, there is no change in size of the chamber, but the pressure rises tremendously. At the end of this phase, because of the ventricular pressure exceeding the pressures of the aorta or the pressure in the pulmonary artery, the semilunar valves will open up. Once the semilunar valves open, the ejection phase of the ventricular systole starts, in which blood is actively being ejected into the aorta and the pulmonary trunk from the ventricles. During this phase, the pressure in the aorta starts increasing as it receives more and more blood, such that the pressure in the aorta or the pulmonary artery becomes more than the pressures in the respective ventricles, and it causes sudden closure of AV semilunar valves because of backflow of the blood from aorta towards the ventricles. This sudden closure of semilunar valves produces what is called as the second heart sound. The second heart sound marks the beginning of ventricular diastole. The first phase of ventricular diastole is the isovolumetric relaxation phase. Here again, the size of the chamber and the volume of the chamber will remain same, though the muscle or the cardiac chamber is relaxing. The pressures fall tremendously. Because of this decreasing pressures, the pressure in the ventricles now becomes less than the pressure in the atria. Once the pressures in the ventricles have become lesser than the atrial pressures, the atrioventricular valves will open up. And this produces rapid filling of the ventricles because of the greater pressure difference existing between the atria and the ventricles. This rapid filling or this rapid flow of blood from the atria to the ventricles can produce a sound. This sound has been given the name as the third heart sound. This phase is called as passive ventricular filling as there is no active contraction seen here. This continues into the slow filling phase as the pressure gradient between the atria and the ventricles now gradually becomes lesser. The speed of flow also decreases and it becomes more slow. And near the end of diastolic phase, the atria start to contract and push the blood into the ventricles, which is called as active ventricular filling phase. So you have seen we have gone into a full circle of events as seen in the cardiac cycle from atrial systole to ventricular ejection to ventricular relaxation or diastole and back to atrial systole. These cyclical changes go on occurring with each heartbeat. These same changes which we have just now discussed are depicted here in the form of a diagram. This diagram is very important in cardiac physiology. So I have on the upper side on the x-axis the phases of cardiac cycle and on the y-axis the pressure and the volume change. Let us start with the left ventricular pressure. The left ventricular pressures is depicted shown here as the solid black line. The left ventricular pressures are usually less during diastole. At the end of diastole, during the last phase, where atrial systole is occurring, there is slight rise of pressure, followed by the ventricular systole, first phase of ventricular systole, that is the isovolumetric contraction phase, rapid rise of pressure. Pressure increases more than that of aorta, causes opening up of semilunar valves. The ejection phase, further rise of pressure as the volume of blood in the ventricles starts to decrease, more and more blood is being pushed into the aorta. So the pressures also decrease till the pressure in the ventricles becomes less than that of aortic pressures. The semilunar valves close. With closure of semilunar valves, there is production of sound, which is called as the second heart sound or S2. Then S2 signifies the start of ventricular diastole. So it's first phase of ventricular diastole, isovolumetric relaxation phase, rapid fall in pressure. This fall in pressure continues till it becomes lesser than atrial pressures. Once the pressure in the ventricles is less than atrial pressures, AB valves open, atrioventricular valves open, and filling phase, the diastolic filling phase continues. There is no change in the pressure as the ventricles are relaxed, but filling is continuing till it goes to the last phase of ventricular diastole, that is atrial systole, where there is again slight rise of pressure. And at the end of atrial systole, the pressures in the ventricles exceed that of the atrial pressure, causing closing of atrioventricular valves and production of another heart sound, that is S1 or the first heart sound. The duration of the cardiac cycle from S1 to S2 is taken as systole, and the duration of cardiac cycle from S2 back to S1 is taken as diastole. Here you can also see the third heart sound coinciding with the passive rapid filling phase, and we can also mark here the fourth heart sound coinciding with the atrial systole. So you have S3 and S4 during diastole. Let's discuss these changes in the left ventricular volume. So if you see the volume of blood present before the start of systole or at the end of diastolic phase is around 125 to 135 ml. This volume present at the end of diastole is called as the end diastolic volume. It is called as end diastolic volume. Then starts the ventricular ejection phase, ventricular systole and ventricular ejection phase, and slowly the blood inside the ventricles starts decreasing as it has been pumped out into the aorta, and the blood remaining at the end of systole is called as end systolic volume. It is called as end systolic volume. End systolic volume is usually equal to around 50 ml. If you subtract the end systolic volume from the end diastolic volume, you can get the amount of blood which has been ejected into the aorta with each heartbeat, called as the stroke volume. So from the end diastolic volume minus the end systolic volume will give you the stroke volume. Look at the aortic pressure changes also here. The aortic pressure changes has been depicted in the red dotted line. The aortic pressure before systole at the end of diastole are lesser, it is around 80. Then as the ejection of blood starts into the aorta with opening up of semilunar valves, here in this case aortic valve, the pressures in the aorta increase along with the pressures in the ventricles. Then as the volume of blood being ejected decreases, the pressures in the aorta also decreases, following the similar pattern as the ventricular pressure. At one time, the pressures in the ventricles becomes lesser than that of the aorta, and at this moment, the semilunar valves close. At this point, the pressures in the aorta are higher than the pressure in the ventricles. So according to pressure gradient, the blood will try to flow from the aorta into the ventricles, but the aortic valves are closed. So this blood, flowing blood, will come hit the it will hit the closed aortic valve and be reflected back. And this is shown in the picture here, in the graph here, as a slight rise in the pressure. This slight rise in the pressure is called as the dicrotic curve, and the notch or the slight indentation which you can see here, it is called as the dicrotic notch. The slight depression or indentation you can see is called as dicrotic notch. Now just see the ECG also. Any electrical event always precede the mechanical event. So P wave will precede atrial systole, QRS complex will precede ventricular systole, and T wave will come before ventricular relaxation. There is another pressure curve seen present in this picture, that is the atrial pressure curve seen here as a blue dotted line. The atrial pressures increase slightly during atrial systole. Then they are followed by a slight rise in the pressures during the isovolumetric contraction phase of the ventricles because of bulging of the tricuspid valve into the atria. Then as the ventricles go into ejection phase, the atrial pressures decrease. They continue to increase slowly as the venous blood is getting collected into the atria. So by the end of the first phase of diastole, continuously there is filling of the atria and rise of pressures in the atria. And as soon as the AV valves open, again the pressures will fall down. So these pressure changes which we have seen in the atria are very nicely seen in the internal jugular vein. So you can see the pressures occurring, changes occurring in the internal jugular veins over the neck. In the neck, you can see these pressure changes. And if we check these curves, we find that there is the first curve, that is the A curve, because of atrial systole, the pressures increase. This is followed by open, closure of atrioventricular valves, produce S1. Then it starts isovolumetric contraction phase of the ventricles, bulging of cuts into the atria, produce rise in pressure, that is called as C wave, and followed by the ejection phase of the ventricles. There is indrawing of these cuffs into the ventricles and produce decline in the pressure. This is followed by the closure of semilunar valves and produce S2 and start of ventricular diastole. And all this time the atria are receiving blood from the uh, veins, from the superior vena cava and inferior vena cava. The pressures continuously increase gradually because of venous filling, and as soon as the AV valves open, as soon as the atrioventricular valves open, the blood passes from the atria into the ventricles, and again the pressures in the atria go back, decrease. That causes the Y wave in the jugular venous pressure curve. Before we finish, I just want to tell you a few points on the left ventricular pressure volume loop, which is very, very important to understand the functions of the heart. In this curve, you can see in the x-axis the left ventricular volume, and on the y-axis we have the left ventricular pressure. Let us see the changes from point A. Point A is the diastole of heart. At this point, the atrioventricular valves are open and blood is flowing from the atria into the ventricles. The ventricles are getting filled. The blood volume is slowly increasing. Then from A to B, the last phase of ventricular diastole, atrial systole. The atrial systole contracts and active ventricular filling, and there is slight rise of volume as well as pressure. At the end of diastole, the pressures in the ventricles is higher than that of the aorta. The atrioventricular valves close, and because the AV valves have closed, we get the sound S1. And the amount of blood, the volume of blood present at the end of diastole is called as end diastolic volume. S1 signifies start of ventricular systole. At this point, the first phase of ventricular systole, isovolumetric contraction phase, occurs, which causes rapid rise of pressure, but the volume is same. At the end of isovolumetric contraction phase, the aortic valve open, and this ejection of blood from the ventricles into the aorta, and because of ejecting of blood into the aorta, the volume starts decreasing. So at the end of systole, the volume of blood at the end of systole, which is present inside the ventricles, is called as end systolic volume. At this point, the aortic valve closes and produces what is called S2, produces the heart sound S2. S2 signifies the start of ventricular diastole. First phase of ventricular diastole, that is isovolumetric relaxation phase. Rapid fall in pressure, but the volume remains same and come back to the point A where we have started. If you subtract the end diastolic if you subtract the end systolic volume from the end diastolic volume, you can get the stroke volume. So the difference between the end diastolic and the end systolic volume will give you the stroke volume. And furthermore, if you want to check the cardiac function, we can calculate the ejection fraction. Ejection fraction is the percentage of blood ejected out, the percentage of blood in from the end-diastolic volume ejected into the aorta. Normally, about 50 to 55% of blood in the end-diastolic volume is ejected out into the aorta, and it can be calculated by using this formula, which is SV over EDB times 100. With this, we end today's session. Thank you for your listening, and I wish you best of luck.